Welcome back to Infinite Intelligence. I'm Infinite, and today we're continuing our claim denial series with part 2. Last time we tackled the top 10 denials that hit practices the hardest, and today we're diving into 10 more denial types that you need to know about. These are the sneaky ones, things like experimental services, modifier mix ups, coding errors, and benefits exhaustions that can sneak up and derail your claims if you're not careful. Before we get into it, don't forget to like, subscribe, and share this video with your fellow biller or coder. And if you're serious about mastering denial management, check the link in the description below. I've created an extensive PDF guide that goes deeper, much deeper, into strategies and examples, all at affordable price. Grab your notebook because part 2 is loaded with valuable tips. Let's get started.
Step into the world of infinite intelligence, where knowledge meets entertainment and brilliance. You'll find the answers to life's greatest questions. With every video we spark new obsessions. Infinite intelligence, we here to elevate. Unlock your mind and let the wisdom resonate. We dive into the depths of the universe unknown. Infinite intelligence and knowledge is our own.
10 Common Claim Denials in Healthcare Billing, Part 2. Mastering challenging claim denials that revenue cycle teams face daily. This comprehensive guide provides practical solutions for the complex denial scenarios that can significantly impact your practice's financial health and operational efficiency. What we will be learning on today is denial definitions, clear explanations of what each denial type means and why it occurs in healthcare billing process. Real-world examples, practical scenarios you'll encounter in daily billing operations with specific case studies. Prevention strategies, actual tips and best practices to prevent denials before they happen. And lastly, resolution techniques, step-by-step guidance for successful appealing and overturning denials. Okay, so let's get into our first denial, which is experimental and investigational service denials. And what does that mean? Payer denies claim when they consider a procedure, treatment, or medical device to be experimental, investigational, or not yet proven effective through clinical trials. This occurs when the services lack sufficient scientific evidence or hasn't received appropriate regulatory approval. Now, what is a common example of this? A patient receives a new type of gene therapy for cancer treatment. The insurance company denies the claim because the FDA has only approved therapy for research purposes and not for standard clinical use. All right. So in this scenario, what would be some preventions or preventative measures that we would take? All right. So first we would get into verifying coverage for new procedures before performing them. All right. That is being proactive about your process. You would like to check payer medical policies regularly, as well as obtain prior authorization when required. And I'm gonna also add this: if there just so happens to be a reason for you have obtained an authorization for a particular procedure, but when the physician goes in, a different procedure has to be performed. There needs to be some type of process in place for those type of scenarios if something were to change. All right. So, resolution strategies provide peer-reviewed lectures supporting the procedure. Next, you want to submit clinical documentation showing the medical necessity. All right. And lastly, consider appealing with expert physician opinion. So all these things can be submitted to the payer for you to possibly overturn the denial through a reconsideration or appeals process. Next, we have the modifier denials, which is very huge. Understanding modifier denials. Modifier denials occur when the wrong modifier is used, a required modifier is missing, or multiple modifiers are applied incorrectly. Modifiers provide additional information about the services performed and are crucial for proper claims processing and reimbursement. So I do have 3 examples here. First one is missing modifier. There is a bilateral knee surgery coded without modifier 50, which identifies that a bilateral procedure has been performed, and it is only resulting in a payment for one knee instead of both procedures performed. All right, so you have obviously we have 2 knees. Operation was performed on both of them. So if we are missing a modifier 50, we're only going to receive payment for one knee. So we want to make sure we have that 50 in place on that procedure code to identify what has been performed in that surgery. Okay. Number 2, incorrect modifier. Using modifier 76, which means repeat procedure by same physician, instead of 77, which means repeat procedure by another physician when a different surgeon performs the second surgery. So if 2 physicians have performed surgery, we want to make sure that we use the correct modifier to identify that, because 9 times out of 10 on that claim we're going to have 2 physicians on the claim. So obviously it's not going to make sense for you to have a modifier 76 on the claim and there's 2 physicians on the claim. All right, so we want to make sure that we are billing them correctly with all the information on the claim being reflected thus and such. All right, next we have conflicting modifiers. Applying both the 25 modifier, which means significant separately identifiable E&M services, and modifier 57, which means decision for surgery on the same claim when only one applies. Okay, so what is a pro tip? Maintain an updated modifier reference guide and conduct regular training sessions on proper modifier usage for your coding team. And like I have said in past videos, there are other tools out there, softwares out there. There's a website called Craneware that helps you with, when this needs a modifier and all those little things. So you want to make sure you have access to those correct systems to help you with these issues. Okay. Next, we have coding errors and types of coding errors, which include invalid or mismatched codes, represent one of the most common denials in healthcare billing. These occur when CPT, HCPCS, or ICD-10 codes do not align properly or when outdated codes are used. Okay, so some examples include unspecified diagnosis code when specific codes are available. Next, we have using deleted or outdated CPT codes, as well as ICD-10 codes. ICD-10 codes that do not support medical necessity, and mismatched procedures and diagnosis codes. So we want to make sure that we are up to date on the codes that are being used, as well as you want to, and I've seen this a lot, you want to be as specific as possible when you are using especially diagnosis codes to describe what is going on with this claim, what has been performed to the pinpoint. You want to pinpoint it out. So just constantly using unspecified diagnosis codes is not going to get you the reimbursement that you were expecting if those codes are available. All right. So first you want to identify the error, review denial reason, and compare submitted codes with current coding guidelines and payer requirements. All right, so it's different payers have different requirements. You want to correct code, update the appropriate current code that accurately reflects services provided and diagnosis treated. And lastly, you want to resubmit the claim by filing a corrected claim with proper documentation supporting the new code selection. All right. Next, we have charge capture and entry errors. Accurate charge capture is the foundation of successful revenue cycle management. One missed charge can cascade into multiple billing issues. All right. And they do have a role called the charge master, which is someone that is if you work at a hospital, that is responsible for making sure that the codes and the charges are updated, so you won't have a lot of billing issues when you're billing these claims through the systems that you're using. All right, so first we have missing charges. Services performed but not captured in the billing system, such as supplies used during procedures or additional physician consultations during hospital stays. And there is a lot of times that I've seen missing charges on a claim. So I have to send it back to where it goes to get that information updated. Now, this next one is a huge one, which is incorrect quantities. Billing the wrong number of units, like coding 1 unit for a medication when multiple doses were administered over several days. And like I mentioned earlier, you can use Craneware, and this is just one system. I'm pretty sure there's others out there, but you can use tools like Craneware to help you. And Craneware is not always right. Someone let me know that the other day, but it's always been right for me. But to help you with knowing how many units go with a medication or procedure, because you will not get reimbursed, or your expected reimbursement will be incorrect if you have the wrong unit. So if your expected reimbursement set up to pay for 600 units, but in all actuality only 400 units can be billed, you want to make sure when you're validating that what's going on here. Is it the units, or was the expected reimbursement incorrect because we had the wrong setup in the system to begin with? All right, and you want to make sure you're always documenting that information when you're doing your research on why it hasn't paid as expected. All right, so wrong service dates. Entering the wrong date of service, which can cause coordination of benefit issues or eligibility problems with the patient's insurance coverage. Implementing daily charge reconciliation processes and provide regular training on proper documentation to prevent these costly errors. And that is true. That's true with authorizations. I have received authorizations sometimes, and the authorization, it's there and it's approved, but guess what? It's for a totally different days of service. And I have to go send it back and see if we can get this information updated, because I need an authorization for the service in question. All right. So sometimes if you have authorization, you want to make sure what are the approval dates for that authorization. Okay. Next, we have workers' compensation coordination issues. Injury occurs. Patient injured at job but seeks treatment using health insurance instead of workers' compensation coverage. All right, so that will cause a denial. It'll come back saying patient has workers' compensation benefits. So you want to make sure you're billing workers' compensation first before you're billing the health care coverage. All right. Secondly, wrong payer billed. Health insurance denial denies claim because worker compensation should be the primary payer for worker related injuries, such as the example that I just gave, and must obtain worker compensation information for resolution. Must obtain worker compensation information and rebuild correct payer for coordination of benefits properly. All right. So, what are some prevention strategies for this particular type of denial? We want to always ask, is this a work-related injury during registration? That is one of the first questions that they ask you when you're going to the doctor. Is this work-related? All right. So they can know off the bat, hey, I need your workers' compensation information. You want to verify workers' compensation coverage before service. You also want to train front desk staff to identify potential work-related cases. And lastly, maintain updated contact information for employers and carriers. Workers' compensation claims require different forms, authorization processes, and fee schedules than traditional healthcare insurance. Okay? All right, next we have benefits exhausted denials. When patients hit their coverage limits, this is huge, especially with Medicaid Arkansas. All right. And I'll just give you like an example. Like, for example, Medicaid Arkansas only pays for like 24 days inpatient. So if you have a stay for, let's say you stay for 30 days in the hospital, they're only going to pay a 24-day per diem. And in other cases, sometimes they may have a per diem, but it's not going to be the same amount uh, for additional days. But there's a whole nother process in play for that. And 9 times out of 10, that may not happen. So you want to make sure you are aware of these limits. All right. So let's get back into it. You have annual maximums. Patient has reached their yearly benefit limit for specific services like physical therapy visits or mental health sessions. All right. Next, we have lifetime benefits, rare but serious situations where patient exhausted lifetime coverage for certain conditions or treatments. And I have never seen that as of yet. Next, we have service specific limits, which are benefits exhausted for a particular service category, such as durable medical equipment or home health care. All right. It is always important to remember to always verify remaining benefits before scheduling services. Consider cash payment options or alternative treatment plans when benefits have been exhausted. All right. So work with the patients to understand their options, including payment plans, secondary insurance coverage, or alternative treatment approaches that may be covered under different benefit categories. All right. You want to be well aware of that. All right, next we have place of service code error. I've seen this as well. Common place of service mistakes. Using incorrect place of service codes can result in immediate claim denials or reduced reimbursement rates. Each location where health services are provided has a specific 2-digit code that must match the actual service location. Okay? such as Code 11, which means you are located, and this happened in a doctor's office, used for a physician's office, but incorrectly applied to hospital outpatient services. Okay, so you want to make sure you are being able to identify these codes, all right? Because hospital outpatient services is totally different from a physician having their doctor's office. I said the doctor's office, but being in a physician office, okay? Code 22, which is outpatient hospital, requires for hospital-based services, but often confused with office visits. A lot of hospitals have outpatient uh, offices, which is totally different from a physician office. All right. So it does get a little confusing, but the code for that would be code 22. And your NPI will be able to tell you what you are as well. And code 23, which is emergency room, must be used for all emergency department services. Okay. All right, so you need to have a verification process. Establish a systematic verification process where billing staff confirms the actual location where services were provided before coding claims. Next, you want to have staff training in place. Provide regular training on place of service codes, especially when your practice operates in multiple locations or provides services in various settings. All right. And lastly, you want to have documentation review. Ensure medical records clearly indicate where services were performed to support proper place of service code selection. Very clear, very concise. Okay. All right. Let's go ahead and mosey on to the coverage termination issues, which is understanding coverage termination denials. These denials occur when a patient's insurance coverage ended before the date of service, but the claim was still submitted to that payer. This commonly happens due to a job change or non-payment of premium or administrative errors in coverage effective dates. Okay, so what do we do with this? We want to verify coverage. Always verify coverage before providing services, not just eligibility. Okay, you want to make sure you're checking coverage and eligibility. Okay, they go one and the same, but they're not the same, but they're one and the same. Next, we want to have real-time checks. Use real-time eligibility verification systems to confirm current coverage status. All right. Next, we want to have documentation. Maintain records of all eligibility verification for claim support. And lastly, you want to have alternative coverage. Help patient identify alternative coverage options when primary insurance terminates. Okay, when coverage terminates, denials occur. Work with patients to determine if they have alternate coverage or if services need to be converted to self-pay arrangements. All right. So next, this is very common, we have contractual obligation denials. All right. So there are contract violations. Claim denies because services weren't provided according to the specific terms outlined in the provider-payer contract agreement. Very big, very huge. All right. Next, we have authorization requirements. Services performed without prior authorization as specified in the contract terms and conditions. All right. That's super huge. And that happens a lot, especially at the hospital. All right, next we have network restrictions. Claim denied when patient is seen out of patient providers for services that must be performed within the network. And lastly, we have documentation standards. Insufficient documentation that doesn't meet the specific requirements outlined in the payer contract. All right. So, contract management. You want to maintain current copies of all payer contracts. You can use a or create a quick reference guide for common requirements. Regular contract reviews help identify changes in authorization requirements or coverage policies. Okay. And sometimes these excuse me, these type of denials slip through the cracks. Okay, because emergencies can often happen anywhere. So, if you're, I'm gonna say, if you live in Tennessee and you wind up going to Virginia and something happens, obviously you're gonna be out of network. So that can go into a denial. Like I mentioned earlier, authorization requirements. You might have the authorization for a procedure, but something happened where another procedure had to be performed, or something occurred. You need to have steps in place to update the authorization you have, or make sure that you have an authorization. And everything else is self-explanatory. Okay. Moving on to documentation denials, the foundation of successful claims. Documentation denials occur when medical records do not provide sufficient evidence to support the services billed, or when required documentation is missing entirely. These denials can be particularly frustrating because the services are often medical necessity and properly performed. So you want to make sure that you have complete medical records, ensuring all services are thoroughly documented with clear notes describing the medical necessity and treatment provided. Okay? So there is no shortcuts when it comes to medical records. You need to make sure all aspects of that medical record is there. You want to make sure that you have provider signatures. Verify all documentation includes proper provider signatures, dates, and required attestations. Okay? In the correct place. No stamps, you know, legible, all that type of stuff in reference to provider signature. Supporting evidence includes relevant test results, imaging reports, and consultation notes that support the diagnosis and treatment plan. And lastly, documentation review, implementation, implement regular documentation audits to identify and correct common deficiencies before claims are submitted. Okay, so you do want to have a team in place, a person in place that is reviewing this documentation, which there is a certification for that, to make sure the documents are correct and suffice to go ahead and get the correct reimbursement for the procedures that were performed. Okay, so the best practice is to create documentation templates and checklists for common procedures to ensure consistent, complete medical records. All right. So your action plan for denial prevention. 1, you want to have a daily habit. 2, you want to have weekly reviews. 3, you want to have monthly training. And 4, you should have quarterly audits. Implement verification processes for eligibility, authorization, and documentation completeness. Conduct weekly denial trend analysis to identify recurring issues. Provide monthly coding and billing updates to keep staff current. And perform quarterly comprehensive audits for your entire revenue cycle team. Prevention focus. Invest in upfront verification and training to prevent denials rather than spending time on appeals and rework. And this is huge right here. This is huge. I do a lot of rework. Technology solutions. Utilize eligibility verification systems, prior authorization tools, and claim scrubbing software to catch errors early. And lastly, you want to have team collaboration. Foster communication between the clinical, coding, and billing teams to ensure complete and accurate claim submission. Mastering these denial types and watch your clean claim rate improve significantly. Remember, prevention is always more cost effective than correction. All right? And that wraps up part 2 of our claim denial series. Today, we've covered 10 more denial types that every biller and coder need to know, such as experimental or investigational services, modifier denials, coding errors, charge capture errors, coordination of benefits issues when workers' compensation should have been billed first, benefits exhausted, place of service denials, coverage termination denials, contractual obligation denials, and finally, documentation denials that come from incomplete or missing medical records. Each of these can cost your practice time, money, and sanity. But now that you've got the insight to stay one step ahead, if you found this video helpful, don't forget to like, subscribe, and share this video with your fellow biller, coder, or a person that's just interested in this type of information. And if you want to dive deeper, you can support the channel by grabbing the affordable PDF with a more in-depth analysis in the link in the description below, packed with examples, denial management strategies you can use immediately. And if you would like to support Infinite Intelligence, please check out my eBay and Mercari shop, where every purchase helps me create valuable content for this community. Thank you for watching Infinite Intelligence. Until next time, stay sharp, stay proactive, and keep those denials in check. Bye.